It's now my distinct pleasure to introduce our keynote speaker, Dr. Ferime Okonlami. Dr. Okanlami is Assistant Professor of Family Medicine and Physical Medicine and Rehabilitation at Michigan Medicine. He's also the Interim Director of Services for Students with Disabilities, as well as Director of Adaptive Sports at the University of Michigan. Dr. Okanlami was born in Nigeria and immigrated to the United States as a child. He completed undergraduate studies at Stanford University as a scholar athlete, achieving academic All-American recognition in track and field. He earned his medical degree from University of Michigan and entered the orthopedic surgery residency program at Yale. He then went on to the University of Notre Dame to earn a master's degree in engineering, science, and technology entrepreneurship, and completed his family medicine residency at Memorial Hospital in South Bend, Indiana. I met Dr. Okanlami a couple of years ago at the American Association of Medical Colleges annual conference. When I first heard him speak, I knew this was someone who could convey essential truths with clarity and with conviction. Dr. Okanlami invites questions throughout his presentation, and while our group is too large for you to ask questions live, I encourage you to type your questions into the Q&A at the feature at the bottom of your screen. And you may pose questions either using your name or anonymously. So, Dr. Okanlami, welcome to NETR.
Thank you, Dr. Williams. I just want to take a second because I think that for some of you, the things that you just heard were probably new. They're probably news to you. I just wanted to start by first thanking, Dean Keppen and Dr. Williams for this invitation. But I want to start by saying, over the past few months, people have asked me the question of, how are you doing? And many people assumed that I was going to give some answer of, well, just making it day by day, and it's just really, really hard. And what I've said to people is that my life is no different over these past few weeks or months, but clearly something is different for you. So what is it? What is it that is different to you now? Because none of this is new. None of this surprises me. And in fact, at this point, none of this even angers me anymore because it's been happening for so long. Now, my goal for today is not to just incite anger and to bring up injustices that have occurred, but is hopefully to get this institution to commit to actual tangible change. Now, we are all in various stages of this change. We are all in different places and institutions that have different resources. However, one of the things that is very clear is that institutions put resources behind things that are priorities. Now, I'm giving all this preamble and background before I actually go into my talk for today, but as Dr. Williams said, I invite all of you to then submit questions or comments throughout. If you see me looking over this way, it's because I have another monitor on that side, and that's where the chat feature is for me. And so I will try to then make sure that I'm seeing if you're putting things in there. You can send them privately, you can send them anonymously, but I want this to be more of a discussion and a conversation rather than me talking at all of you, because watching that presentation, it's clear that there are at least several students in this organization, in this institution, that know what's going on, and they want to then have action. They no longer just want conversation. And so therefore, what I hope for today is that at the end, there can be something that is a commitment. And what I'm going to do, I told Professor Williams that I never prepare my presentations because I don't want to give some sort of cookie cutter presentation. I want to know what's happening at each institution. And because of COVID, because of timing, this was an invitation that she sent to me months and months ago. And to be honest, I forgot why I was even invited. I forgot what I was supposed to be talking about. But then given what's been happening recently, what I'm actually going to present to you all is something that I already gave. This is a presentation that I gave at another medical school, and you will hear it. There's no secret. This was at Dartmouth. And it was an actual sort of a modification of a TED Talk that I was about to give a few days later that has since been aired. So I don't usually like, as I said, to prepare things. I don't usually like to read, but given all that was just presented, I think that it would just be it would be a disservice to you all and a miss if I don't read to you something that was written months ago to see if it resonates with you all right now. I want to reiterate, this was something that I wrote and presented months ago, and how strikingly it then connects with everything that was just shown, everything that was just said, I think shows the fact that this is not something that should be seen as new, and we are far beyond the time where we need to be talking about plans and we need to have action. So once again, I invite you all to be in this. There will be some slides that will be playing through, and I'm going to read this presentation to you all. All right. I titled this, "Won't You Be My Neighbor?" Like many other people around my age, I grew up watching a TV show called Mr. Rogers' Neighborhood. And the theme song began with the words, "It's a beautiful day in the neighborhood." But when that first episode aired in February of 1968, there were many neighborhoods that were not singing that song. In many states, Jim Crow laws mandating racial segregation in all public facilities had been legally enforced until 1965. And with the assassination of Dr. Martin Luther King Jr. in April of 1968, it was clear that life was very different, depending on what neighborhood you lived in. But that was over 50 years ago, and has absolutely no lasting impact on what happens today, and certainly has no place within medicine or medical education, right? The golden rule says to treat your neighbor as yourself, but it does not say who we should consider to be our neighbors, or that we should ignore those who are not. In psychology, there is a phenomenon some refer to as the familiarity principle. Put simply, it states that people tend to develop a preference for things that they are familiar with. But it is difficult to become familiar with something that you are intentionally being shielded from or refusing to acknowledge yourself. Thus, Jim Crow laws mandating racial segregation exacerbated an already problematic societal structure by preventing people from getting to know one another. As physicians and physicians in training, we would hope that our education leans more towards the golden rule and less towards the familiarity principle when it comes to its impacts on the care our patients receive and the way we see and treat our colleagues. But today, I'm going to use the COVID-19 pandemic to discuss just how things of the past are still affecting the care of people that fall into two specific neighborhoods due to the inextricable link between healthcare and society. First, however, I think it's important that you become a little more familiar with me. My family moved to the United States from Nigeria when I was young. Both of my parents were already physicians, but were required to repeat their residency training in the States and did so at Howard, Johns Hopkins, and Georgetown before we all moved to Indiana, where I completed elementary and junior high school. I then went to Deerfield Academy, a college prep boarding school down the road from you all in Western Massachusetts, before attending Stanford University for undergrad, where I captained the track team, served as class president, and graduated with honors before matriculating to the University of Michigan Medical School, and then matching into orthopedic surgery residency at Yale. I went on to earn a master's degree from Notre Dame, was appointed to the St. Joseph County, Indiana Board of Health by Pete Buttigieg, and completed a family medicine residency in South Bend before returning to Michigan to join the faculty in the departments of family medicine and physical medicine and rehabilitation. As a male physician, I acknowledge the position of privilege I am in, and I am extremely fortunate to have a job that has given me access to excellent healthcare. However, it is difficult to see the disparate impact COVID-19 is having on people that look just like me, due to a variety of reasons that have very little to do with the decisions that they've made themselves. At the same time, without knowing my background or hearing my pedigree, I know that I am still viewed by many as just another young Black man. Whether I am driving in my car, paying cash at a convenience store, or going for a run. And my lived experience and health outcomes in that neighborhood are vastly different than the level of privilege my male physician status affords me. At the same time, I am seen by many as an African before I am seen as Black, which could be considered both prejudice and privilege, depending on who you ask. And even worse, I am often told that I don't even see you as black. Or people will say, yeah, you may be black, but you are different. Almost always intended to somehow make me feel better, but just further driving the point home that black lives are treated differently. Belonging to these distinct neighborhoods has made it impossible for me to ignore the fact that the way I am perceived by others has less to do with who I actually am or the intersectional way with which I view myself, and more to do with that individual's perception of what neighborhood I primarily belong in. No matter how long my white coat or how visible my stethoscope, there are still people that cannot see beyond the color of my skin. By now, most people have seen that it is communities of color that have been disproportionately impacted by COVID-19, but some are still asking why. The World Health Organization defines the social determinants of health as the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. They are mostly responsible for the health inequities, which are the unfair and avoidable differences in health status seen within and between countries. They include factors like socioeconomic status, education, employment, social support networks, and access to healthcare. Right now, people around the country are becoming increasingly more aware of the driving force behind these factors: racism. There is a double dose of disparity being felt by our most vulnerable neighbors right now. Racism had already negatively impacted their health outcomes, and through epigenetics, we also know that the history of trauma experienced by generations of Black and Brown people that came before us has a measurable impact on our health outcomes today. And now the pandemic, with its resultant shutdown and quarantine measures, has begun to hit the same communities from all sides. National data have shown that the COVID-19 death rate is 6 times higher in areas that are predominantly non-white when compared to areas that are predominantly white. In a piece written by my colleague, Dr. Mlk Day, a Black female emergency physician who lost her own Black husband to a heart attack in his 30s, she discusses societal factors like access to healthy food, housing, and employment, and the role that they play in the uneven prevalence of chronic diseases that make COVID-19 more dangerous in these minority communities. And it must be said that these social determinants of health are not due to chance or choice, but are instead tied to our long history of racial segregation and structural racism. For those who are quick to dismiss these as things of the past, a recent study showed that some graduating medical students believe Black people don't experience pain the same way other races do. And just the other day, I was discussing the unforgettable history of mistreatment carried by the National Health Service during a recent Tuskegee study of untreated syphilis in the African American male. A study which knowingly withheld the diagnosis of syphilis and its available treatment from the Black men enrolled in the study. This continues to be cited as one of the reasons why mistrust of the healthcare system still exists in many minority communities, which may manifest in not accessing available healthcare services or not trusting the recommendations of their physicians. Some students came away from this discussion feeling discouraged, wondering how they would ever be able to dismantle the structural racism that was built long before their arrival. If we consider death to be the ultimate result of poor health, then the countless deaths of Black people like George Floyd, Breonna Taylor, and Ahmaud Arbery should be enough of an indication that our lives and our health are not seen as equal by the very institutions that are meant to protect us. In order to change the culture of these institutions, we must start by connecting with individuals. This is precisely what a group of University of Michigan medical students is doing with STEER HD, which stands for Students Teaching, Educating, Evaluating, and Reducing Health Disparities. We partnered with Walgreens and Omron Healthcare to deliver patient education about high blood pressure and provide free blood pressure monitors to those in need in our neighboring communities. Repairing the relationship that communities of color have with the healthcare system is possible, but will take a consistent commitment to doing so and an honest assessment of why the relationship is so damaged in the first place. I imagine that the same thing may need to happen amongst some of you. Some of you that still don't think that there is a problem with medicine. Those of you who do not understand why some of your classmates are so angry right now. And even the well-intentioned ones that just don't believe it is the school's place to say anything about racism and are offended by the very notion that the curriculum may need an anti-racist overhaul. I have been learning from my medical students during this time about some of the race-based practices that I was taught in medical school, but never questioned. It was through their efforts that I read more about the work being done around the country to eliminate the use of race as a factor in the VBAC score, spirometry, and estimating GFR. But we should not expect our students to be responsible for educating us when we are being paid to educate them. The second neighborhood I wanted to reference is the disabled community, which has also been vulnerable and marginalized for quite some time. Now, before you roll your eyes thinking I'm about to launch into an all lives matter argument, bear with me. The CDC identified individuals with the following disability types as being at increased risk of becoming infected or having unrecognized illness. People who have limited mobility or who cannot avoid coming into close contact with others who may be infected. People with intellectual or developmental disabilities who may have trouble understanding information or practicing preventative measures. And people who may not be able to communicate symptoms of illness, like members of the deaf community, unable to read lips with everyone wearing face masks. But now, with social distancing, shelter-in-place recommendations, and the state of our healthcare systems, disabled people are in an even more vulnerable position. People with disabilities and chronic health conditions fear that their lives were already seen as less valuable, and now worry that due to limited resources, care will be rationed if they are hospitalized, skipping over them in favor of individuals with lives worth saving. A few weeks ago, I did a video visit with a patient of mine, paralyzed due to a spinal cord injury, who has recently lost 160 hours a month of caregiver services, something that was already hard to come by before all of this. He now worries about the infected pressure sores on his bottom that were being tended to by these in-home caregivers because he had to cancel that necessary service given the inconsistent and unpredictable manner in which these aides were observing social distancing recommendations. There is a silver lining here, however, because due to the familiarity with the lack of accessibility, there is much we can actually learn from the disabled community right now about how to be creative in the face of uncertainty. I often tell the following story a man once told me about his son. The man's son was colorblind and in kindergarten. His homework would say, "Color the circle blue." Yet somehow he was always able to get it done. One day the man finally asked him, "Son, how do you get your homework done? It says color the circle blue, but you're colorblind." His son looked at him with this perplexed look and said, "Dad, I never use crayons that aren't labeled." Often the solution to a problem is much easier than one may imagine, especially when we listen to the voices of those that are impacted by it. But who is actually being impacted by the things that are going on right now? It once again comes back to who you consider to be your neighbor. If your next door neighbor's house is on fire, you may believe it impacts you because you actually know your neighbor, or you may even love your neighbor. But it might just be because you fear that your house may catch on fire next. Despite being an orthopedic surgery resident that took care of people with disabilities, I did not really know or understand the experience of the disabled community myself until 7 years ago. When I broke my neck in a diving accident, paralyzing me from my chest down and moving me into the neighborhood of disability and sparking my passion for addressing iniquities that exist due to the intersections between disability and race. Though I was a physician that took care of patients with disabilities myself, and I thought I was being a good neighbor, I truly was not. But not due to an intentional desire to ignore their needs, but simply because I was not aware of what they were. In medicine, we can no longer pretend that we do not see the problem. I am sitting here today in a special wheelchair that assists me in standing upright. I have done many surgeries and medical procedures in this chair, which has provided me with a simple solution that has allowed me to have more access to the profession that I love. I now live in this neighborhood of disability as well, seeing other disabled people as my neighbors. Even though if you had asked me before, I would have said that I always saw them as my neighbors. But I clearly didn't recognize the way that their homes were burning down until I was living in that same neighborhood with them. Whose houses are burning down within the Geisel, Dartmouth community that are still going unnoticed? People often wonder how much of a difference any one person can make. But both of these pandemics, COVID-19 and racism, have shown me that institutions are just structures that have been built upon the beliefs of a few individuals with the power to move the needle. I'm going to repeat that line. COVID-19 and racism have showed me that institutions are just structures that have been built upon the beliefs of the few individuals with the power to move the needle. Each of us has that same ability to make a difference by being an ally to support and validate the lived experiences of others, speaking up when the popular opinion excludes the needs of our most valuable or vulnerable, and whenever possible, looking around the table, taking stock of which voices are silenced or missing, and creating the space for them to contribute directly. While each of us does have that ability, there are certain people with the positional power to enact the necessary changes. Correcting centuries of historical injustices perpetuated against the Black community requires a radical departure from what we are currently doing. Right now, medical students across the country and right here are sending a very clear message to their institutions that the time to act is now. Racism is a public health and medical crisis, and our students are demanding that we dismantle our already broken healthcare system, incorporating comprehensive anti-racism and health justice curricula for students, faculty, and staff, putting an end to race-based practices in medicine, and establishing a culture of intolerance for prejudice of any kind. 2 years ago, I was invited to give the Mlk Day Talk for your institution, once again, Dartmouth. I was honored by the invitation and was well cared for. Being put up in the historic Hanover Inn. During my talk, however, I drew specific attention to the fact that the very history that the Hanover Inn proudly displays on its walls is not one that included anyone that looked like me. And not because people like me wouldn't have been capable, competent, or qualified, but because the history of institutional and structural racism is one that prohibited us from being there in the first place. It was during that talk that I used the following line that I have come to use quite frequently since then. The past may not be your fault, but the future will be. Despite what I look like and the injustices I have experienced, I myself must admit that I didn't make my own radical departure from what I was doing until after I broke my neck. Having to experience firsthand how it felt when I wasn't able to get in somewhere due to a lack of access reminded me of the experiences of those that weren't allowed to go in somewhere due to racism. I was then forced to relive all of the micro and macro aggressions that I have endured to get to where I am today as a Black man in medicine in this country, past traumas that I do not speak about every day for fear that I will come across as the angry Black man in a system that is clearly not made for people that look like me. I spent this morning texting Dr. Stephanie White, a friend, colleague, and former Dartmouth faculty member at your institution. She shared your Instagram account with me, and I then spent more time reading the posts from Concerned Student 1797, which was called A Voice for Students to Speak Freely Regarding Diversity, Equity, and Inclusion. I encourage GEISO leadership to spend some time on there as well, in case there is any confusion as to the experience your students are having and have been having. I always thought that because I have personally experienced the discrimination, that I wasn't also complicit in perpetuating a racist system. But merely stating that you are not racist is not the same thing as actively denouncing racism and supporting an anti-racist curriculum. What is it going to take for you to be able to see that these problems are also your problems too? You can't all become disabled Black Nigerian physicians, but it shouldn't take having the same lived experience to acknowledge the implications of racism and ableism on those that you may not have considered your neighbors yesterday. However, my hope is that after this talk today, you will begin to consider them your neighbors tomorrow. We are only as healthy as our most vulnerable neighbors. And unless we adequately care for them, then you too may find yourself having the lived experience that you never thought would impact your own beautiful neighborhood. We are all in this together. Therefore, I will end my message with an invitation, in the same way that Mr. Rogers always began his. Let's make the most of this beautiful day. Since we're together, we might as well say, would you be mine? Could you be mine? Won't you be my neighbor? You can remove the slides now. Thank you, Becky. Now, as I was preparing to then figure out how I would follow up my own talk with the talking points that I wanted to continue with, I was then sent a link from this double AMC article that just came out today, which was from one of my colleagues that I spent time with as an undergraduate at Stanford, and then I ended up spending time while we were both at Yale together. And this will then be the segue into what I would like to discuss some more about my own experiences, because unfortunately what's happening right now is that the world and the nation are starting to pay attention to certain things that have been the lived experience of many of us for a long time. Now, that can be disheartening at times that people feel as though this is new, but we have an opportunity to then capitalize on their feelings and their emotions that they are now paying attention to it. And I don't mean capitalize in a negative way. I mean, we must leverage this momentum at this point to actually make actionable and sustainable change. But I'm going to read this to you because my own experience has been one that has not necessarily been the best over the past few weeks and months that this has been happening. Because as hopefully you can see, even if it's just across a computer screen, I'm not afraid to share my thoughts about the things that I think need to happen and the things that I have not been the first to then verbalize or vocalize ever. However, for whatever reason, people are starting to pay more attention, and I've been blessed with the platform to be able to speak about these things. I, however, gave a grand rounds at my own institution, and during that grand rounds, I highlighted the fact that the community that is predominantly Black and Latinx in our area is one that is not resourced in the same ways that the rest of our communities are. And I called the institution to visit our clinic that we have in that community and see if it stands up the test to look like the other community structures that we have and some of our more affluent communities, or some of the neighborhoods that aren't considered the bad neighborhoods. At the end of this, there were many, many people that were thankful that I brought this up, but I was contacted by a senior leader that said that I had now effectively lost any chance at getting a leadership position at this institution because I called the institution out publicly. Now, I say this because this individual was actually trying to help me. They recognized the structure that existed, and they realized that institutions do not necessarily like to be called out on the things that they are not doing well, even if those things are public knowledge and are visibly apparent when you look at the structure with which we send our patients to in that community and compare it to the other one. But by merely speaking up and saying it, I was then jeopardizing my own longevity at my own institution. Therefore, when I hear the reports of these students that have been uncomfortable or scared or unwilling to come forward with their own micro and macro aggressions for fear of retaliation, it is true. And even today, when I speak to students, I cannot in good faith encourage them to report all of the things that have happened, because I do know that while there may be a safe reporting structure in place, it is a human being at the other end of that reporting structure that has this unconscious or sometimes very conscious bias, and I can't guarantee that there will not be retaliation or retribution yet. And that is why I'm going to read this article that was penned by my colleague that perfectly encapsulates the way that I've been feeling over the past couple of weeks and months, but that I hope that nobody else ever has to feel this way again. So her piece was titled, and you can find it, as I said, literally today is when it was posted, "Why I Gave Up My Dream of Leading Diversity Efforts in Medicine." I loved mentoring students of color, lecturing about implicit bias, and creating courses that promoted health equity. But I couldn't manage it all. Schools need to provide more funding if they want to create truly inclusive and supportive environments. After forcing myself out of bed, I made it to my rounds with less than a minute to spare. It had only been 3 months since I started seeing patients and teaching trainees at a major academic medical center, and already I was feeling overwhelmed. I had discovered that my assigned 1.5 days of clinical duties in a psychiatric clinic actually required 3 days of work to oversee the care of more than 100 mostly poor Black and brown patients. Many had substance abuse disorders and very serious mental illnesses. As a woman of color, I wanted to serve them well because they seemed to trust me more than the prior providers that they had had. That often meant I found myself working far into the evening. In addition, as an attending at a major teaching hospital, I had numerous other obligations. On paper, I had my dream job. In reality, I often felt dragged down. Not much earlier, while in residency, I dreamt of becoming a leader in the field of diversity education, hoping one day to be a dean of diversity or a dean of students. I had become the go-to person in my academic medical community for lectures on bias, consultations on diversity curricula, guidance on working with minority patients, and more. I also published research papers and narrative articles to educate my community about diversity. Though demanding, I loved this work. I truly believed that academia could support patients, providers, and communities of color with the help of engaged stakeholders like me. Only things didn't go as I'd planned. While working in the psychiatric clinic, where I was the 4th attending in almost as many years, I had 2 other jobs. I led efforts to develop a social justice curriculum for the Department of Psychiatry's residency program, and I served as the director of the Standardized Patient Program for the School of Medicine, which involved recruiting and training lay people to act as patients for students learning to become physicians. I often felt overworked and unsupported. Through all this, I also wanted to continue to serve as a mentor to Black and brown students, residents, and colleagues, sharing any professional guidance I could offer. Soon they began to come to me with personal input, gut-wrenching stories of discrimination, and I even found myself in a position of having to decide whether to report a former supervisor who was now a colleague. I felt terribly alone. So few of my colleagues shared my identities. I'm a Black queer woman, and many of them were white men. As a new faculty member, I often felt unable to turn to my prior sources of social support, given that they were now technically my subordinates. And I bore the stress of feeling other outside of work as well. I was frequently the only African American when I went out to a restaurant, and the national socio-political climate felt increasingly hostile to people like me. The stress was no longer than a moment or moments. It was endless. It started to affect my ability to function well. I lost track of emails and tossed and turned most nights. My immune system became weak from all the stress, and I got the flu twice. So I decided to leave. As long as the culture discouraged asking for help, didn't fully value those whose focus on innovative diversity education, and failed to provide sufficient support to minority faculty, I would never feel truly safe. I knew members of my medical community appreciated me and my work, but unless they intended to use their privilege to prevent Black and brown faculty from leaving, it was not worth it to stay. Although it was the most difficult decision I have ever had to make, I know it was the right one. Yet I continue to feel like I abandoned my Black and brown patients, trainees, and colleagues. I cry when I learn of the distress of my friends and former colleagues. Often when we catch up, I cannot help but feel re-traumatized by their experiences and weighed down by a heavy sense of guilt for leaving. I'm also terribly sad that non-minority allies don't speak up or provide them with support. I have since found a relationship with an academic institution that feels safe, but I still struggle. I continue to see patients and hand-pick teaching opportunities. I cautiously choose diversity efforts that allow me to go beyond conversations about implicit bias and really get into the complicated nature of systemic racism. Meanwhile, I find myself hoping for progress in academic medicine, though I'm not completely optimistic. Senior physician leaders of most academic communities continue to look the same, unlike the rest of the United States, which is becoming increasingly diverse. Senior leadership in many places also continue to express support for diversity without actually providing real support for diverse faculty, educational initiatives, or institution-wide policies that foster inclusivity and equity. Often academic medicine focuses on implementing effective medical education for trainees, and that's important. But medical schools and teaching hospitals need to do much more to create a culture of inclusivity at every level across the entire institution. They need to create clear, strong policies that support employees from racial and ethnic minority backgrounds. Then they need to train all staff in those policies, support reporting of breaches, and make sure to enforce the institution's rules and values. Institutions also need to make long-term investments in hiring and promoting faculty of color, providing administrative support for faculty of color, and funding diversity education at all levels comparable to that of other initiatives. All this needs to happen not just during newsworthy moments of controversy, legal action, or protest. What happens when all of the public shifts its attention away? More importantly, what happens to those who need initiatives that never get implemented or that run out of funding in a few years? We need real change with strong policies and programs backed by solid funding for them. Verbal support is not enough anymore. If we don't make these changes, minority members like me who once hoped to educate trainees and support patients will leave as they find they cannot shoulder the burden alone. Callie Cyrus, MD, MPH, is a practicing community psychiatrist in Washington, D.C., an assistant professor at Johns Hopkins University School of Medicine, a founding member of Time's Up Healthcare, and a diversity consultant. Now that was just today. What I started with was what I wrote weeks ago. I invite you all into this conversation. Please start by putting any questions that you may want in the chat. But I want to create this as a discussion that continues long after I leave. I tell people that I have the luxury of coming into your living rooms or your offices or wherever you are right now and having this conversation and dropping a few bombs, but then I leave and the discussion needs to continue. And it needs to continue as more than just discussion, and it needs to be actionable, tangible items. Now, I'm actually encouraged by Dean Keppen that he read a few things that are the blueprint for what is going to happen here. Now, I didn't have an opportunity to really engage with him prior to this, so this is a conversation that I will have with him, and I'm not asking for a response here unless he wants to. But I encourage that to move beyond a blueprint even prior to the end of your tenure. Because I'm sure, as you know better than even I do early in my academic career here, as someone that comes in new to a dean of an institution, they're going to be bombarded with all sorts of priorities and all sorts of things that they must need to do. And I think that if this is something that is truly important to this institution, it need not wait for a new dean. I believe this is something that can be implemented before the new dean comes so that when that individual starts, they can hit the ground running and do not have to then advocate for the resources to create the systems that you want to create. Now, the other thing that I will bring up that once again, I never do any of these things to incite anger or to point something out that I feel as though it's an attack on someone, but even watching the presentation of the state of the institution at this time and seeing the leadership that was created, that when this institution started in 2011, 13, I believe, when the institution started and you brought together your team, it was not lost upon me looking at that team that that team was still a rather homogeneous group of institutional leaders. So my hope is that as we are creating new systems, that we make sure that the people that we have representing the leadership of our institution represent the diversity of ideas and thought and experiences and opportunities that reflect the population that we're going to serve. Now, this is once again no negativity to Dean Keppen. This is no slight in your decision making, because I'm sure that all those individuals were wonderful and were qualified. And so by no means is this to say that the institutional leadership wasn't qualified to do their job. But this is just meant to say that there was an opportunity to start then with individuals who could have demonstrated what you wanted the institution to look like. And at this point, I hope that you can continue to do that as we're moving forward. Now, I was looking in the chat, but I see that questions have started flying into the Q&A. So I'm going to start by looking at those. So if you give me a second, I won't read all of them out, but I will start to read some of them. And I think those that are not anonymous, I will read so everybody can hear what they are. So one says, I grew up in Philly, attended a public school that was a majority Black, and my life experience drives me to return to Philly and provide excellence in primary care to medically underserved areas, specifically in the city. As a white woman, I want to address the real distrust towards doctors that may exist in many minority MUAs, but I am generally passionate about improving health outcomes in my city and implementing health policy changes to address disparities. I have to consider that people may not trust me as a white doctor due to the generations of mistreatment and dismissal by medical bodies. I know there isn't a specific protocol for this, but I want to know your opinion on the need for more doctors that represent their own communities, but also those like myself who care specifically about these communities but do not want to cause more harm for people with my presence when someone else may be better suited for the role. Now, thank you for that comment. I will be able to address that very directly. The way I feel is sometimes not always a popular sentiment. I personally don't care what anybody looks like, because if you are passionate about the work, I invite people to do the work. Too often there are people that feel as though you have to then look like the people that you serve, and there have been data that have been published recently talking about racial concordance. Now, I believe that racial concordance data leads us down a slippery slope of saying that if we can find out that Black people are cared for better by Black people, that will then lead to people doing studies that show that white people are cared better by white people, which will then not lead to truly diverse, equitable, and inclusive systems. So therefore, I know that there is a white savior complex that some people fear that will be put upon them. And I actually invite all people, because that's why I have these conversations. It's truly about diversity, equity, inclusion in the broadest sense. But that does not mean that when you say that Black Lives Matter, you are disproportionately, and unfairly putting resources towards a community that shouldn't be getting them. And so I'm very careful when I say these things, because while as a physician, of course, I understand that to me, all lives do matter. I do support the need to say that Black lives matter, because until we say that, until we do that, until we demonstrate that, there has not yet been evidence that they do. And therefore, we need to make sure that we put systems in place that protect them. But no matter whether you are Black or white or purple or blue, I think that you should be allowed to do that work. And in fact, I encourage people to do that work. And this is going to require people that look alike and people that look different to work together to be able to demonstrate that this is something that should be important for all of us. It should not be something that is then just thrust on the shoulders of the minorities to do all of the work. I actually use some analogies and examples when I talk about things, right? Dean Keppen said that this is a start. Now, everyone needs to start somewhere, and so it's great that we're starting now. But I do think that if we acknowledge that this is a start, that means that we're also admitting that we had not begun yet. And that means that we were not actively doing these things. And this is what students across the country are frustrated about. Because I use the example of, if a physician at an academic medical institution said, I'm not really familiar with teaching about diabetes. and I'm not exactly sure how to then manage, insulin. What they're not going to do, they're not going to find the type 1 diabetic in your class and send them the curriculum of the endocrine sequence and say, does this look okay? They're not going to ask you to form a diabetes task force with students, faculty, and staff from across the institution to then decide how to teach about diabetic management. They're not going to then ask you to stand in front of the class and show your class how you then inject your insulin and how you calculate your carbs to determine what the dosage should be. But that is what we do with issues of DE&I right now. We are putting it on the shoulders of our students to teach us what we need to do to then take care of the next generation. We are willfully acknowledging that these issues of DE&I, these things of systemic oppression and justice, are things that we weren't taught and that we're not comfortable with. Therefore, if we're willing to acknowledge that we are not comfortable with these things and we do not know them ourselves, why do we continue to promote people to associate and full professor and put them in charge of the educational curricula of students that have been clamoring for this information? The students are the ones leading the way teaching this, and that needn't be the case. If you think about it with respect to diabetes, if you think about it with respect to anything else that we know how to teach, you would no longer be teaching students if you said, I'm not exactly sure how to then teach you how to auscultate a heart. And so, you're gonna have to teach me how to do that yourself. What are your suggestions? That individual would not be doing standardized patient exams. They would not be teaching students how to do them, and we would find a way to rectify that problem. So I invite all of us in this conversation to say, if we are starting now, we need to truly address what the gaps are and fill them with people with the expertise to do so, and not rely upon our students to be the ones to lead the way to teach what we need to do. Next question. Do you think that the pandemic has shown us that we are all bound as healthcare providers, some with more skill sets than others, and all healthcare recipients, some with more disease than others, with the goal of us all upping our skill sets, allowing us to expand our ability to care for ourselves and each other? Yes, so I think that this shows that we are not all just bound as healthcare providers, but I think this has shown that we are bound as human beings in this country. Because COVID-19 does not discriminate. While it does impact people disproportionately, it does not discriminate. It is people that discriminate. And so therefore, if we can acknowledge that this COVID-19 pandemic has made us all come together as a world, as a nation, and as individual communities, because we're acknowledging that the decisions of others, the decisions that other people make about how they are going to then adhere to face masks and adhere to social distancing has an impact on our lives, I think that is just a little example of how we can talk about how diversity, equity, and inclusion, and systemic injustice and racism impact all of us. Because prior to this, we did not see how people were connected to others. We did not see how an injustice that then afflicted just this minority population truly impacted us, because we did not see ourselves in those communities. But now, because everybody is worried about what the cashier is doing at Meijer or Kroger or the pharmacy, everybody then has to get into each other's business to see, are you wearing a mask? Are you social distancing? Have you had symptoms? And we are now realizing how interconnected all of us are as healthcare providers and specifically, and as people in general. This one is anonymous, so I'm not going to read it out loud in case it's not wanted to be. Sorry, just give me one moment. This is a long one. Wonderful. So this one was not really a question, but it does say it was a question, but I'm not going to read it out loud. Essentially, this was someone that was referring to the systems of reporting and reporting concerns of culture. And so I think that this is an important point to bring up, because while I said that I want to make sure that people are acting and not merely talking, this individual said that it's important to recognize that there are times that the action is talk, because there are many things that we do not, and please feel free to correct me if I'm misinterpreting this, but there are times that we are not discussing the things that are happening, right? Like the example in the video of the resident leaving the room and then the patient saying, oh, the nurses are here. And while the attending corrected them, they never talked about that again. That is a small microaggression that then will be there will be lasting impact on that student, because even though the attending corrected the patient, which doesn't happen most of the time, to be quite honest, that was an opportunity to then have a conversation with that student, to then directly state how you felt about that interaction and that it should not have gone that way, and that you could have then empowered that student to then think about how they could have then addressed that some other time. So I do think that talk is important to make sure that we are talking about the things that are happening, but I do want to make sure that we are talking to each other and not behind each other about things that are happening. And so thank you for that question. Another comment here. Oops, these things are coming in quick. So I want to make sure that I am giving things to you that are specific to you. So there was a question directly about my thoughts on the Dean's Blueprint. So I commented on my belief that I think it's great to have a blueprint. I think that I took notes on it so that I can even refer to it. Review and revise curriculum where appropriate. What I will then say, and this is once again just Dr. Okanlami N of 1 unfiltered commentary. So revise and review curriculum where appropriate. I would just encourage that term of where appropriate is something that then does not create a barrier to revising curriculum that someone at some point deems is not appropriate to be revised. I think that there are many people that are doing work across this country to demonstrate what anti-racist curricula can look like. And since we are all connected, I do not think that we need to operate in silos and ignore the work that has been done elsewhere. I think that there are wonderful examples of how we can do this, and each institution can then partner with other institutions to see that. And as one of my roles is that I'm the disability issues representative for the AAMC on the group on diversity and inclusion. And I know that the Council of Deans meets. I've actually spoken to several of the deans about some of this work. And so that is something that there could be a way. Now, every institution is different, and therefore you cannot mandate. The AAMC makes no mandates about these things. So they cannot mandate that this be the same curriculum that everybody adopts. But I do know that deans talk, and you can talk to other deans that have been working on their own anti-racist curricula and implement these things such that you don't have to have a long of a turnaround time to implement something merely because it's new to you when it's not new to other places. So I think that's something that's important. The other points of the deans: establishing appropriate support for DE&I office. Now this is a funny statement for me, because oftentimes when I give talks, I say, and I'm invited usually by diversity officers to give the talk, and I tell them that my dream would be that we no longer need a diversity office. And I say that I would hope that we no longer need a diversity office for the same reason that Dean Keppen brought up, that diversity is everybody's responsibility. Now, this is a very careful statement, however, because I hope that we get to a point where we do not need diversity offices, because diversity should be everyone's responsibility. But the unfortunate truth is that when something is everyone's responsibility, it becomes no one's responsibility. And there are no resources directly allocated to it. There is nothing that is specifically responsible for making sure this thing is implemented. And therefore, it is very easy for it to not find its way on any agendas and for it to be brought up once a year at an address. And this is not saying, this is, once again, I don't know much of your system, so I do not want any of these to sound like direct indictments, but I don't want it to seem as though it comes up in an annual address, but then in between there, it has no home. So the fact that this is something that has been accepted by the institution, I actually personally look forward to checking back in with you in a few months to see what the progress has been on that. Because if there's going to be a decision to actually create a DE&I office and support it, that's going to take conversations with budget and finance early, because I know the way that these systems work, and we're not going to be able to all of a sudden come up with a budget for money that doesn't exist, especially during the COVID pandemic time. And so I think that if that is a decision that wants to happen, there needs to be work done to then secure the financial resources to make sure that happens. Because just like my own institution, I'm sure that you are under budget cuts and have actually had to cut programs. And so it will be exceedingly difficult to start a new program during this time. And that is just some of the honest, real conversation that I want your institution to be able to have, because it will sound great to then have a list of things that are going to be a blueprint, but without intentionally reaching out to then implement these things and allocate the resources to doing so, it could be something that in a year we throw our hands up and say, well, we just weren't able to do that. So I do think that the things that were outlined by the dean are a wonderful starting point, as he said, but in order for it to be a starting point, something needs to start, and the start should be things that don't actually require conversation to do. That one is one where putting it in the budget and making the plans to then have that, you don't need to know the curriculum, you don't need to have the job posted even, but you just need to have the money set aside to doing so. So I think that that's great. So someone says, how can I start conversations like these with my white peers, especially if I sense their lack of care about the experiences of people of color? So this is why I hopefully demonstrated my own vulnerability when I started this conversation by saying that even though I was a physician that took care of people with disabilities, I did not fully appreciate the difficulty and the lack of accessibility of our world. So, I like to say I tell stories and I give analogies, but it's like, let's say that there's a restaurant that I really, really love going to, right? And I went to this restaurant all the time and didn't even realize anything off about the restaurant, but loved their food, right? After then I became disabled and now I use a chair to get around primarily, is when I realized that that restaurant doesn't have an accessible entrance, is on a road that there's no curb cut out to get onto the sidewalk, has 5 big stairs to get in, and then has a second story with no elevator. I did not realize when I was attending that place prior to my disability that it wasn't accessible. But what sometimes happens, and this is where, I never tell someone how to advocate, but let me show you 2 sides of this coin as to how sometimes these conversations go. There may be someone that then now, post-injury, goes to anyone walking into that restaurant and says, how dare you patronize this establishment? Don't you know how they are holding up systemic ableism and they don't have a ramp to get into this building? They have no elevator and these places are just wrong. You shouldn't buy food from any of these places. How dare you be so ableist to eat there, right? Now, the person that was going in the restaurant, they didn't need a wheelchair to get in. They didn't need a walker to get in. They've walked up those stairs countless times and they never thought about who was actively being shut out. And so there are some people that do not realize, and I mean this, it's a hard pill to swallow. Some people don't realize that racism, ableism, sexism, all of the isms are alive and well today. And we could choose to be the ones that then attack them to say that they are wrong for not realizing that. And our anger is well founded because these things aren't new. But just as another human being, it is not necessarily going to be something that that individual will receive well if we start by telling them all the things that they have done wrong when they didn't even realize they're doing anything wrong in the first place. Now, this is a very difficult conversation to have because one could ask, how could you not have known that this was happening? How could you be living in 2020 right now and not realize that these things occur? And that's why I led with my vulnerability, that even when I was proximal to what I thought the issue was, I did not know of others' lived experiences, but it is through conversations like this, it is through being able to create policies that intentionally address the people that you do not see, because it just takes one person having a seat at the table to bring up the conversation, but then it takes the person who is at the head of the table to foster it. Because all of us that don't have all of the institutional decision-making power can speak until we are blue in the face, but until the individuals that have the power to move the needle recognize this as important, it won't change. So for your white colleagues that then don't realize this is a problem, some of them, it's not their fault they don't realize it's a problem. And others of them may realize it's a problem, but don't know what to do. And then yes, there are still some that do not want to see this as a problem. And that is not negative, that is just reality. And so each one of you is going to have to choose how you want to advocate. Because at the end of the day, you have to do what you are able to then look yourself in the mirror at the end of the day and be satisfied that you made an impact. And I will tell you that while I may seem very inflammatory today, the route that I have chosen to take is not, many people are familiar with sort of the Martin versus Malcolm argument. And I am somewhat of more of the Martin and not the Malcolm. Now, for those of you that don't understand that, I tend to go with the sort of the peaceful approach. But that does not mean that I criticize some of my peers who have been much more vocal and much more seemingly negative in their approach and have been more of a Malcolm that want to burn the system down because they say the system is just so terrible that we just have to rebuild it all. We cannot count on trusting any part of the system. And the good cop, bad cop symbiotic relationship that I sometimes have with those people is that If it weren't for them ruffling a lot of feathers, I wouldn't then be invited to be the person to speak, because I think that I've started to demonstrate that while I can be very honest and direct in my assessments, I try to be even in my doling out of opportunities for improvement, because my hope is that people want to improve. I know that some people don't want to, but in reality, my goal is not to first convert the ones that don't care into all of a sudden caring. My goal is to make sure that those that do care right now, that are in positions that they can change it, are given the opportunity and the resources and the support to do so. Because if we alienate those that may want to help that are sitting right next to us, as we move through your medical school, your residency, your fellowship, those people are not going to be any closer to you. If you go back to the familiarity principle that I talk about, if people do not get to know you and your struggles, if people don't get to hear the problems that exist, even though they should know about them, right? Even though I feel as though it's ludicrous that people in 2020 can still say that they don't think these things are happening, that ship has sailed. I'm no longer arguing with why people don't know. I'm just making sure that they now can no longer say that they didn't know. And as I said, the past may not be your fault, but the future will be. So you just have to come at it with hopefully an open opportunity to then teach and learn, because we all have a lot that we can learn. None of us is the expert in any of this. I am just the expert in my life. I'm not even the expert in Black lives. I'm not an expert in male lives. I'm not an expert in disabled lives. I just happen to be a disabled Black male physician that then has experiences that I can draw upon to show people that this is real life. And fortunately or unfortunately, the stories that I could tell, if I had told these stories in December of 2019, most people wouldn't believe me. But the stories that I could tell right now, people finally actually acknowledge that those things probably happened. Because beforehand, everyone is asking, well, what did you actually do? You know, what did you say to that person? Or are you sure? And it's something that even in the position in which I sit, it's still difficult, because I read my pedigree not trying to pat myself on the back, but it's because my private school, Deerfield, Stanford, Michigan, Yale, Notre Dame education still has not protected me from the injustices that exist. And then when I choose to talk about my pedigree, instead of being then commended and referenced that the achievements that I have then attained are because of merit, the same thing is said that, well, you probably just got into Stanford because you're a Black athlete, and you got into medical school because of affirmative action, and then this and that, and there are always excuses that are made that are not, no one wants to then recognize the merit that I may have had. There's always an explanation for why I got to that point. So this is part of the frustration of this double-edged sword, is that if I get the education to look similar to my colleagues who had all of the privilege, there's still an asterisk next to my name that makes the impression that I didn't get those things fairly just like they got theirs. But the fact that they had generations of people that went to the institution, the fact that their parents, you know, played golf together at the country club, those aren't things that are factored in. And I don't blame your colleagues for having those networks and those connections. But the fact that when those same networks and connections are then something that I tried to then capitalize on, I'm called an Uncle Tom. I'm called a sellout. I'm then, the people then talk about how I'm, you know, taking advantage of the system. And so these are the things that I told, you know, Professor Williams that at one point she may have to rein me in, because the reality of this is that none of these conversations are new. And I'm looking forward to each individual institution recognizing that, so that in a year from now, I am not invited to give more of these talks at other institutions, because it's quite frankly exhausting. And if I am a faculty member in the position that I am in that is still relatively protected, I can only imagine the exhaustion of every single student that has been going through their educational career, having to face the same things and not knowing what someone's going to do or what they're going to put on their dean's letter, not knowing if they're not going to match because they actually spoke up. That is something that I need more people to speak up about, to then make sure students know that they are safe and protected. Because if they are acknowledging the same thing that the rest of us are seeing in the world, that what's going on, they should not then fear that by bringing it up, they're going to then have adverse consequences. So I'm going to keep on going back.
So I
Yeah.
just want to be mindful of time. There's 7 minutes left, so maybe one more question.
All right, and I think this is a good one to end with. Social justice is equal protection, equal treatment, treating others as you wish to be treated. I'm tired of racism being ascribed to whites as if just being white makes you racist. I am appalled by the anti-Semitic BS from the left walkists. Now, I bring that up because I want people to see that even in these conversations, I'm happy that people share their opinions. Now, hopefully, there was no part of my talk that gave the impression that I was blaming racism on white people and that I was saying that by simply being white, you are racist. Because I never even referenced that myself. And I want everyone to know that racism, sexism, ableism, systemic injustice and oppression is not is not owned by any one demographic group. This is something that all demographic groups suffer from. All of us are human beings. And so I want to end this by saying, I'm inviting everybody to recognize that while racism exists, I did not blame racism on one race. Now, the history of our institutions and of our country cannot be ignored, however, because there were certain demographic groups that were disproportionately impacted by the way that our country was founded. And that is not something to blame other people for today, but if people fail to acknowledge the implications that that continues to have, we're not going to move forward. We're not going to. So I think that there are plenty of people that need to acknowledge that this is a problem, regardless of the color of your skin, regardless of your gender, regardless of your sexual orientation, regardless of your profession. This is something that impacts all of us. And I don't want this to be something that just a minority group then feels as though it's their responsibility. And I don't want this to be something that any one minority group says that it is the fault of another group. So I want to be very clear as we end right now to say that at no point do I want any particular demographic group to be singled out, because as a privileged physician man from a Nigerian family who is told that I'm the whitest black guy people have met, there are people in the black community that don't accept me. There are people in the white community that don't accept me. I have been too black for white people. I'm too white for black people. I'm too African for Americans. I'm too American for Africans. I'm too disabled for able-bodied folks. I'm too able-bodied for disabled folks. I'm too much of an athlete for the scholars. I'm too much of a scholar for the athletes. So my entire life has been about intersectionality. My entire life has not been about parsing out who I am and pitting one part of me against another part of me. Many of you do not, most of you, almost none of you know my life, right? I have a son who has a white mother. And so my entire every single day is trying to explain to my son why no one part of him is bad. He shouldn't feel bad about being white, just like he shouldn't feel bad about being black. And my son is both black and white. And so this is something that is important to me to the core. And it's still unfortunate that our nation and our institutions have not been able to get to a point where we can reconcile differences. And instead of pointing fingers, we can look around and see that we are all more connected by things than we are disconnected. If we communicate with individuals and start to become familiar with each other, we will see that they're going to be intersecting parts of our Venn diagram, that then at the end of the day, when you put all the Venn diagrams together by the different sort of demographic groups that one belongs in, there won't be anybody that's in a circle by themselves, because each one of us touches someone else's life in a way that we may not know. You may have no idea what the intersections of your Venn diagram are until you actually talk to other people and figure out which circles intersect with theirs. And then you will find that by advocating for some of these social justice things, you are truly helping someone that is your neighbor. And that is a family member, a friend, and someone that benefits from all of this work. And it shouldn't be thought of that this work only benefits the minority, because if that's how we still feel, then we have a long way to go to recognize that this work is important for all of us. And with that, I'll stop.
Thank you so much, Dr. Okanlami. That was a tremendous contribution to our community, gave us a lot to work with. We all know that we have much to do here at Netter, and you've definitely given us some guidelines and some focus for the work that needs to be done. So thank you so much. Thank you to everybody who wrote in questions. Thank you to Dean Keppen, to the Crossroads students, and of course, congratulations to our awardees. And I greatly appreciate everyone who joined this conversation today. Look forward to seeing you around campus, so be safe, everyone. Bye-bye.